ladies and gentlemen. Welcome to the inauguration ceremony of the annual academic sessions of the Sri Lanka Society of Gastroenterology. The ceremonial procession is now entering the main hall. Please rise to recognize them. Ladies and gentlemen, please remain standing for the national anthem.
We Sri Lankans take a lot of pride in our traditions. To commence today's proceedings, we would like to light the oil lamp right now. I would like to invite the following dignitaries to light the oil lamp. The chief guest of the event, Dr. Sanjeeva Munasinghe, Secretary to the Ministry of Health. Our guest of honor, Dr. Asela Gunawardena, Director General, Health Services. Dr. Sanjeeva Aryasinghe, the President, Sri Lanka Society of Gastroenterology. Immediate past President of the Society, Professor Ishandi Soiza. The President-elect of the Society for the next year, Professor Rohan Siriwardena. The Treasurer of the Society, Dr. Udaya Kalubowila. The Secretary of the Society, Dr. Hasita Vijayawantha. The Assistant Secretary, Dr. Achini Vithanachi, and the Senior Professor of Surgery, Professor Nandadeva Samarasekara.
Thank you, ladies and gentlemen. You may now take your seats. Ladies and gentlemen, the Sri Lanka Society of Gastroenterology has been the pioneering organization collaborating with gastrointestinal surgery and the medical subspecialty of gastroenterology in Sri Lanka, working towards achieving rapid medical advancements and providing high-quality service to the healthcare for over 3 decades. Tonight, we mark the inauguration of the annual academic sessions for the year 2021, themed Embracing Change and Achieving Excellence. We will now officiate the inauguration ceremony by playing the video clip to officiate tonight's proceedings. I would now like to, while we move on to the next part of the proceedings, I would now like to invite the following dignitaries to take their positions at the head table. The President, Dr. Sanjeeva Aryasinghe, our Chief Guest, Dr. Sanjeeva Munasinghe, the Guest of Honor, Dr. Asela Gunawardena, the Secretary, Dr. Hasita Vijayawantha, and Assistant Secretary, Dr. Achini Vithanachi. I would like to invite the dignitaries to take their positions at the head table.
I would like to invite Dr. Sanjeeva Aryasinghe to deliver the welcome address.
Chief Guest, Dr. Sanjeeva Munasinghe, Secretary, Ministry of Health. Guest of Honor, Dr. Asela Gunawardena, Director General of Health Services. Dr. Nihal Marcus, Orator, Professor Simon Travis, Professor of Clinical Gastroenterology, Oxford University Hospitals Foundation Trust, UK, past presidents of the Society, members of the Council, members of the Society, distinguished guests, colleagues, friends, ladies and gentlemen. It is both an honor and a privilege to stand here as the President of the Sri Lanka Society of Gastroenterology to warmly welcome you to the inauguration ceremony of the annual academic sessions. The origins of the Society, or the Gastroenterological and Digestive Endoscopy Society of Sri Lanka as it was then known, can be traced back to 1988, when the idea of forming a community with gastroenterology as its focal point was proposed by the founder-president, Professor Dayasiri Fernando. A few years later, the subspecialty of gastrointestinal surgery was established by the Postgraduate Institute of Medicine. Soon, with the efforts of Professor Janaka de Silva, the medical subspecialty of gastroenterology was established. These two subspecialties began to change the landscape of gastroenterology in Sri Lanka, and over the years, the society grew from strength to strength and was renamed the Sri Lanka Society of Gastroenterology in 2012. As of 2021, we are happy to note that we have 23 board-certified gastroenterologists and 21 gastrointestinal surgeons. The annual academic sessions are the highlight in the calendar of any professional medical body, and it is the same for our society. However, due to the unfortunate Easter Sunday attacks in 2019 and the COVID-19 pandemic in 2020, we were unable to hold a physical annual congress. The year 2021 dawned with new hope and a new council to steer the society. The pandemic seemed to be receding, and life was seemingly getting back to some semblance of normalcy. But 2 months into 2021, the pandemic was far from over and came back with a more virulent strain. Undaunted, the council stood firm. Pandemics are not new to humanity, and if we look back at history, we see that we have come through them stronger than before. This time, we had the knowledge and the technology to produce new drugs, vaccines in a short period of time. In short, we had the means to change with the times in order to look ahead to the future, and this was evident in the field of gastroenterology as well, and hence our theme for the year, embracing change in achieving excellence. Ladies and gentlemen, our council mapped out an ambitious program for 2021, and as the President, I am proud to say that with the support of the Council and the membership, we have been able to achieve all of them and even more. Let me now digress a little to highlight a few of our achievements during the year. Apart from being on the front line of the COVID pandemic, for us gastroenterologists, we have had to address two other pandemics, the metabolic syndrome and its liver manifestation of non-alcoholic fatty liver disease and obesity. There has also been a rampant increase in the prevalence of fatty liver disease and non-alcoholic cirrhosis in our country, and they contribute significantly towards morbidity and mortality. The cost incurred by the Ministry of Health in their management is enormous, and to address these diseases better, for the first time we have been successful in including them into the National Non-Communicable Disease Program. We look forward to address these NCDs at a national level and thereby hope to reduce the disease burden in the future. We have also been successful in focusing the Ministry's attention on the rise of GI malignancies such as esophageal, colorectal, and hepatocellular carcinoma. The Society is now closely collaborating with the National Cancer Control Program in this regard. In this era of evidence-based medicine, the Society has embarked on an ambitious project to develop clinically relevant, locally produced guidelines on common GI problems faced by gastroenterologists and physicians, and I am happy to announce that the first of these on the management of variceal bleeding in cirrhosis has been completed and will be handed over to Dr. Sanjeev Munasinghe today by the team led by Dr. Mananjala Senanayaka and Jayani Manchanayaka. We hope the ministry will incorporate these guidelines into the NCD program and distribute them as a national guideline. One of the foremost objectives of a professional college or society is to disseminate knowledge about the clinical specialty. The annual academic congress is one such endeavor. Apart from this, we had planned to have some regional meetings in several provinces. However, the pandemic precluded these plans, but the society, without abandoning them totally, transformed it to an online form, and we scheduled a series of monthly webinars on interesting and current topics in the field of gastroenterology. The project was coordinated by Dr. Kulisha Kodisinghe, and I must say it has been very successful, so much so that we have had to add a few more webinars to our schedule as well. Another endeavor has been the introduction of our own newsletter. For the first time, under the purview of our editor-in-chief, Dr. Nandana Dinamitra, we have been able to launch a newsletter to be published every 3 months. And this, along with a modern and revamped website, has placed our society at the forefront of professional colleges and societies in the country. For the specialty to thrive and expand, it is imperative that we pay attention to the needs of our trainees and junior members. Under the leadership of our Assistant Secretary, Dr. Achini Vitanachi, we have been successful in putting together an endoscopy curriculum which did not exist until this year. Today, we are happy to hand over this endoscopy curriculum to Professor Nandadeva Samarasekara, who is the first board-certified GI surgeon. I am sure it will be added to the gastroenterology prospectus once it is approved by the Board of Study in the near future. We have 4 gastroenterology training units in the country which produce our future consultants. Rather than isolating them in their respective units, this year we have brought them together by organizing a virtual journal club under the supervision of foreign experts in the field, and this has been very useful in their training. Since its inception, our society did not have a place to call home. I remember when I was serving as a secretary in 2008, our office used to be the boot of my car. I had to organize council meetings at various locations, and organizing activities was an extremely difficult task. As the society grew in stature, the need of an office grew more acute. Today, I am happy to announce that this year we were able to step into our own office space, and I have no doubt this will help our society to streamline its activities and prosper further. All these achievements would not have been possible without the support of my council. Our secretary, Hasita Vijayawantha, will propose the vote of thanks, but I feel it is my duty to thank him, as I know he will not be thanking himself. Our Assistant Secretary, Dr. Achini Vitanachi, also needs special mention for doing such a wonderful job during this year. Each council member has contributed immensely towards the society, and I thank them all wholeheartedly for their efforts. So, ladies and gentlemen, over the span of this year, our society has certainly changed. We have changed the physical appearance as well as its online presence. We have changed our advocacy role in the ministry, and we have introduced changes for the advancement of our trainees. Over these 2 days of academic deliberations with experts in the field, no doubt we shall see change in the way we practice gastroenterology as well. So, ladies and gentlemen, I believe our society has embraced change in many ways, and I am sure the future will reveal just how much of an impact these changes would have had. Coming back to the highlight of our calendar, the annual academic sessions, when we took office in January, we were planning on having a near-normal Congress, but as the months passed, the pandemic dictated a change in the format to a fully virtual or a hybrid model. Today, we are indeed happy to be in a window period and finally be able to have it as a hybrid Congress. This morning, we were witness to a fantastic endoscopy workshop which was transmitted live from the Asian Institute of Gastroenterology in Hyderabad and the Baldota Institute of Digestive Sciences in Mumbai, India. The workshop highlighted cutting-edge techniques along with tips and tricks from an array of world-renowned masters in endoscopy. We thank Dr. Nageswar Reddy, Chairman AIG Hyderabad, and Dr. Amit Maidev from BIDS Mumbai for their help and support in organizing and hosting this on behalf of the Sri Lanka Society of Gastroenterology. The climax of this evening today will be the Nihal Marcus oration, and we have invited Professor Simon Travis, Professor of Clinical Gastroenterology from the Oxford University, with whom I had the privilege of working with to deliver this prestigious oration. The Society wishes to thank him for accepting our invitation of being this year's orator. Tomorrow, we have a full-day program of lectures focusing on new developments in the field of gastroenterology, hepatology, and GI surgery. We welcome all our speakers, both local and international, who have accepted our invitation to be on our panel of experts and share their knowledge and expertise with us. I am sure this new knowledge will shed more light in the management of GI disease and will certainly make us achieve excellence in the field. On behalf of the Society, I welcome you all once again and invite you to enjoy the sessions, and thank you for your good wishes and your presence here. I wish to leave you with this quote from Charles Darwin. I quote, "It is not the strongest of the species that survives, nor the most intelligent. It is the one that is most adaptable to change." Unquote. Thank you.
Thank you very much, sir. Next, I would like to invite Dr. Jaini Manchanayaka to present the guidelines on management of variceal bleeding in cirrhosis to Dr. Sanjeeva Munasinghe, the Secretary of Health Ministry. Thank you. Next, I would like to invite Dr. Achini Vitanachi to present the endoscopic curriculum to Professor Nandadeva Samarasekara. Thank you, sir.
Ladies and gentlemen, next on the agenda is the address by our guest of honor for this evening, Dr. Asala Gunawardena, the Director General of Health Services. We'd like to thank Dr. Asala Gunawardena for his presence at the onset, at the initiation of the ceremony. However, Dr. Asala Gunawardena had to abruptly leave today's proceedings due to a prior commitment. He is currently at a meeting with His Excellency the President. He, however, sends his best wishes for the inauguration of the academic sessions. We thank him for his presence and for all the support provided to make this event a success.
I would like to invite our chief guest, the Secretary to the Ministry of Health, Consultant Radiologist, and Major General Dr. Sanjeeva Munasinghe to address the gathering.
Dr. Sanjeeva Singh, the President, Sri Lanka Society of Gastroenterology, past presidents, council members, and members of Sri Lanka Society of Gastroenterology. Ladies and gentlemen, good evening. First, I like to thank the President and the Council of Sri Lanka Society of Gastroenterology for inviting me as a chief guest of this inauguration ceremony of annual academic sessions. The annual Congress has been identified as an important event in the calendar of the Society. The Congress provides a strong platform not only to bring together the specialists who have committed their professional journey to this specialty, but also an event that gives an opportunity to all those who have an interest in the field to enhance their knowledge and skills to share in by local and international experts. I have observed that this society is unique among the professional colleges, as it includes both gastroenterologists and gastrointestinal surgeons working in harmony to care for their patients. I have a personal connection with this society, as some of the members, including current president, have been my trainee in their radiology component. As President mentioned, there are 23 board-certified gastroenterologists and 21 gastrointestinal surgeons delivering gastrointestinal services throughout the island. As highlighted by the President, there is a pandemic of diabetes and fatty liver disease. The increasing burden of non-alcoholic cirrhosis and management of its complications are a huge burden, a huge drain on the national health budget, especially in a resource-poor setting. I am happy to note that these diseases have been included in the national NCD list so that due priorities and resources can be allocated. In addition to the liver diseases, the increasing obesity and bad food habits have produced rising trend in gastritis and gastroesophageal reflux diseases. For the management of these diseases and provision of a good patient care, I am aware that the specialty of gastroenterology needs a lot of resources and equipment. Apart from the ward spaces for in-ward patients, you need endoscopy and ERCP facilities, facilities to assess GI physiology, operating theatre times, and good support from radiology and pathology departments. Our goal should be to provide equitable gastrointestinal services throughout the country. And I am aware that at present there are the GI units in teaching hospital, provincial and district general hospitals. There are several requests to develop some of these centers as centers of excellence in GI care, which includes endoscopic interventions, liver transplantation, etc. But I believe we can plan this in stage-wise manner, depending on the priorities and availability of the resources. And I am happy to extend my fullest support and cooperation to society in this endeavor. While thanking organizers once again for the invitation, I extended my sincere good wishes to the Sri Lanka Society of Gastroenterology for continuing in all their future endeavors. Have a pleasant evening.
Ladies and gentlemen, we have now reached the highlight of tonight's agenda, the Dr. Nihal Marcus oration to be delivered by Professor Simon Travis. I would now like to invite Dr. Sanjeev Arya Singha, the President of the Sri Lanka Society of Gastroenterology, to introduce our orator to this audience, who will be joining us from the United Kingdom in no time.
Professor Simon Travis is Professor of Clinical Gastroenterology at the University of Oxford and Consultant Gastroenterologist at Oxford University Hospitals NHS Foundation Trust. He is a former president of the European Crohn's and Colitis Organization, known as ECHO. He trained at St. Thomas's Hospital, did his PhD in Oxford, when Professor Janaka de Silva was also there and has enjoyed collaborating with Sri Lankan colleagues ever since. His research interests are in inflammatory bowel disease, including endoscopic assessment of disease activity, predictive indices, and the integration between science and clinical practice. Over to you, Professor Simon Travis.
And if I just share my screen, then I will have the honor to present the Nihal Marcus oration. And that, I hope, is sharing my screen. And can you actually confirm that you're seeing that, Sanjeeva? Because if I may present the citation for the Nihal Marcus oration, and to the patron, Professor Dayasiri Fernando, council members of the Sri Lankan Gastroenterological Society, Dr. Manel Marcus, his widow and family members, colleagues, ladies and gentlemen. It is indeed a great pleasure to present the 2021 Nihal Marcus oration, which was established in 1988 in memory of a well-known gastroenterologist who passed away, sadly, in 1986. That is Dr. Nihal Marcus. He qualified in 1962 from the University of Colombo and obtained his MD Ceylon, following which he went to England for further training as a Commonwealth scholar, where he went to Edinburgh, and on his return to Sri Lanka as a fully qualified gastroenterologist, he was unable to practice as a gastroenterologist at that time because it was not established as a specialty. Nevertheless, he taught and practiced gastroenterology wherever he worked, which was in Trincomalee, Ratnapura, Negombo, and also in Gale, his last appointment. Although I never met him, all those who had the privilege of working with him still talk about his ability to teach and of his excellent clinical skills. Sadly, in 1986, Dr. Nihal Marcus died, and we lost a fine teacher and a first-class clinician. And I'm grateful to Dr. Manel Marcus, his widow, for sending me these images, these clips you see behind me. And I would just highlight some of the aspects of his career, because when he came back to Sri Lanka as a gastroenterologist, he recognized that he needed a surgical colleague, and that was Dr. now Professor Dayasiri Fernando. And he was above all a pioneer for the common good, working in the social sector as well in preventing TB, and then as a WHO fellowship in cardiology in Denmark, illustrating the diverse interests of a great clinician. And it was his lucidity of expression, clarity of thought, and ability to fire enthusiasm that really comes to the fore of this remarkable man who we're proud to remember this evening. And the topic that I have chosen is one which I hope he would welcome, and that is the care of the hospitalized patient with acute severe colitis as of today and tomorrow. Indeed, it was in Oxford in 1955 that Sidney Truelove at the top there on the right, and Leslie Witts, who was the Regius Professor of Medicine below, defined acute severe colitis in very simple terms: diarrhea with 6 or more bloody stools per day, a tachycardia, temperature, anemia, or a high ESR. And those criteria, established in 1955, have stood the test of time. And the number of criteria, in addition to a bloody stool frequency of 6 or more times daily, correlates with clinical outcome. And my work over the years has been absolutely focused on trying to help clinicians predict outcomes where judgment is called for, and it's difficult, but medicine is difficult. We know that. Professor Benito Hujo, with whom I worked and is a friend, and I believe is in the audience, has looked at those criteria in a South Asian context. He took patients with ulcerative colitis at the All India Institute of Medical Sciences in New Delhi, classified them according to the True Love and Witch criteria, and half of them were hospitalized. And what he showed was that the fecal calprotectin, a stool sample, which is reasonably expensive and costing about 30 euros or 30 pounds per test, but a threshold of 782 micrograms per gram had excellent diagnostic accuracy for identifying the severe attack. And that's a useful way of taking individual subjective judgment out of the equation. So why does it matter? Well, it matters for a number of reasons. The first is that a quarter of all patients with ulcerative colitis have an episode of acute severe colitis, and it's still potentially life-threatening. In Sidney Truelove's original paper in 1955, and almost a quarter lost their lives, but it's now down to between 1% and 3% in the UK, according to a national audit. But the other reason it matters is that it's closely related to the risk of surgery, which is what patients with ulcerative colitis least want to happen. Indeed, if a diagnosis of ulcerative colitis is made, there's a 12% chance of needing an operation. But the patients fall into two groups. The quarter who are admitted with acute severe colitis, that risk during their lifetime is 40%, although it's only 3% for the three-quarters who are never admitted with acute severe colitis. And that, I think, is an important factor to keep in mind when you're managing these patients and managing their expectations. And of course, if you're admitted more than once with acute severe colitis, the likelihood of surgery increases on subsequent admission. And for many years, we thought that the risk of surgery, if you were admitted, hadn't changed. And I'll show you data around that, and I'll show you data that we can help make it change. And the third reason that the acute severe colitis matters and the timing of surgery matters is because the mortality and the outcomes are directly related to the number of days in hospital prior to surgery, and indeed the number of patients that hospital is dealing with. In the lower graph, the color graph there, you can see that the mortality is lowest in high volume hospitals and more than fivefold higher in hospitals which don't often operate for acute severe colitis. This is in Canadian data. And furthermore, in the top right, you see that if surgery occurs more than 10 or 11 days after admission, then it's 3 times higher than if there's early surgery. That's not an advocate to be an advocate for early surgery. It's an advocate for making timely decisions. And you need help to do that. And help is at hand. Not only help in predicting who's going to get acute severe colitis and be hospitalized at diagnosis, but help when that patient's admitted, and that matters for the emergency staff and the house officers, registrars and consultants admitting those patients. Help for the endoscopists during their admission, and also predicting outcome on discharge. This rather complex slide relates to what is really a very simple message, and that is that you can predict the likelihood of being admitted with acute severe colitis, with ulcerative colitis, at diagnosis based on 3 simple factors: the extent of the disease, the CRP, and the hemoglobin. And we did a study in Oxford, subsequently validated in Cambridge and Uppsala, which took those three criteria and applied 1 point if there was extensive colitis, 1 point if the CRP was more than 10 milligrams per liter at diagnosis, and 1 point if the hemoglobin was less than 14 for men and less than 12 grams per deciliter for women. And if you scored 3 out of 3, then our Oxford data showed that the risk of being admitted over the next 3 years after diagnosis was somewhere between 73 and 100%. And these are more data showing the Oxford and not just the Oxford index cohort, but the Cambridge and Uppsala validation cohorts. And in Cambridge, using that simple equation predicted 100% of patients who are going to be admitted. And the Uppsala data in Sweden is particularly interesting because it's population-based with a much larger cohort, 300 odd patients, many more than in Oxford or Cambridge. And their admission rate with acute severe colitis was only 6% overall, compared to about the 25% of patients in Oxford and Cambridge. But this predictive index still was useful, even when acute severe colitis was that uncommon. And so it seems to have stood the test, and we use it at diagnosis in patients with ulcerative colitis in Oxford. Now, the initial management hasn't much changed over the past 40 years, but it has changed and it is changing. First of all, these patients need admitting to hospital. Secondly, they're given intravenous steroids. We use hydrocortisone, but methylprednisolone is a perfectly reasonable alternative. We also use rectal hydrocortisone. And up until recently, we've been giving them intravenous fluids to keep up with their potassium loss. We withdraw loperamide and antidiarrheal agents. We give them low molecular weight heparin. We do pre-screening bloods, and we liaise with surgical colleagues. And we assess the response after about 3 days and make a decision with the surgical colleague whether they need rescue therapy or what. It's worth noting, and I bet it's true in Sri Lanka just as much as in the West, that the risk of venous thromboembolism is materially increased in patients with hospitalized for ulcerative colitis compared to other patients hospitalized for other reasons. And therefore, we give low molecular weight heparin. It's much less common to have venous thromboembolism in a South Asian population, but it is still a material risk. And we do what we call the pre-flight checks in case patients need rescue therapy. But what's changing is that we're replacing the intravenous fluids with enteral nutrition. And that is based on work again by Vinita Ahuja and colleagues, randomized controlled trial, published earlier this year in Elementary Pharmacology and Therapeutics, where he randomized patients admitted with acute severe colitis either to receive enteral nutrition or standard of care, as I've described in this slide, the intravenous steroids and with just eating normal hospital food. And the simple impact of enteral nutrition was striking. And here are the data. Because there was just over 60 patients, recruitment fell foul of the pandemic, but it was still sufficiently powered to show a difference. And you can see in the ITT analysis on the left that the addition of enteral nutrition markedly reduced the incidence of steroid failure. And that's in the gold bars. And only a quarter failed to the steroids if they had enteral nutrition, but almost half failed steroids if they had standard of care. There was no significant difference in the colectomy rate because numbers are small. And when you took out the patients who stopped enteral nutrition, there were 3 out of the 62 then the difference did become significant. And it's been a practice changer. It was an open label study, had to be open label. And I think that in a resource limited society, where we all struggle with resources, but this particularly applies to South Asia, if you can use a simple adjunctive therapy like this to reduce the need for expensive drugs, that has to be a good thing. And I said that the colectomy rate hasn't changed over 40 years. And this is a study that Dan Turner published in almost 15 years ago now, looking at all the reports on the management of acute severe colitis in hospital. And this was before the infliximab era. And you can see that red line going through, which is the colectomy rate. And between 1970 and 2005, it was constant, about just under 30%. And indeed, in Oxford, we're often accused of having too low a threshold for colectomy. But over on the left, I've shown Sidney Truelove's 1955 data. But what about now? It's right down there. It's halved. And those are up-to-date data presented at the BSG earlier on this week. And the question is, why? Well, what's happened and what's changed? If you look at all of our data from my original study when I was a senior registrar and Janica was with me in Oxford, then and you look at a review of all of our patients by Lottie Dinesen and then by an Australian fellow, Crispin Court, over the years, you can see that the rescue therapy, this is the left of those bars, and they're color-coded on the right, but the left of those bars, you can see that the proportion of patients having rescue therapy, either with infliximab or cyclosporin, CSA as cyclosporin, is doubled within that time. And if you look at the colectomy rate, which is over on the right, you can see the colectomy rate is halved. There has to be a message there. So when a patient comes in, their main concern is, am I going to get better? And of course, if they realize that surgery might be on the cards, then the doctors want to know, how do you predict colectomy? And that is really quite simple, because you simply count the number of additional Truelove or Witts criteria. And you remember that all patients have a blood ESOL frequency of 6 or more times daily. And then the pulse rate, the temperature, the hemoglobin, and the SR or CRP are down there. And you can see that if you have just one additional criterion, then there's a 9% chance of colectomy on that admission. And we looked at just over 290 admissions. If there are 2, then the risk is almost a third. But if you have a full house or 3 or 4 additional criteria, it's almost half. And that's an important message, because you can check those on admission and it helps you manage the expectations of the patients. But then, of course, you do an endoscopy, and this busy slide is just to flag up the ulcerative colitis endoscopic index of severity, because I'm going to show you data around that. And it is the only validated scoring system for ulcerative colitis, and some in the audience will have heard me speak about this a lot in the past, but it just looks at 3 factors: the vascular pattern, the bleeding, and erosions and ulcers. And they're very, very precisely defined criteria. And you just top up the levels and you get a score of something out of 8. And it's scored at the worst affected area, and that allows biopsies to be taken, which also help exclude CMV. So we use the UCIS in order, as you see here, to compare normal top left, bad colitis bottom right. And Crispin Court, now in Sydney, showed that if patients on their flexible sigmoidoscopy and admission had a score of 7 out of 8 or 8 out of 8, then almost all of them needed rescue therapy or colectomy. No patient died. And so the severity of disease is the message, and the biological activity is what relates to poor outcomes. And Jack Sasangi and Vipin Gupta, who's come to us from Delhi and is now doing a locum consultant job in Cardiff, has developed a new predictive index. And I'm not a mathematician, but I like indices because they help guide clinical judgment. And he's called it the ADMIT ASC score, the ADMIT Acute Severe Colitis score. And that, like the previous index, just applies a single point for different thresholds. So if you've got a very high CRP, 100 milligrams per liter, you get 1 point. If you've got a very low albumin, you get 1 point. If you've got really bad endoscopic disease with UCIS of 7 or 8, then you get 2 points. But if it's 4 and above, you get 1 point. And what he showed was that not only in our Oxford Discovery cohort, that if you scored 4 out of 4, absolutely nobody responded to steroids. And guess what? That was the same in the Gold Coast in Queensland, Australia, and with Vineet's group in New Delhi. So it's been validated in a South Asian population. And it's simplicity because everybody, every patient can have those simple scores measured. And I commend it to, and we've got that in practice. The other approach we've used for the past 20, 30 years is using the Oxford Third Day Index, which we published, as I say, almost 30 years ago now. And that was to assess the response to intravenous steroids on the 3rd day of admission. And if they still had a stool frequency of more than 8 a day, or if their stool frequency was between 3 and 8 and their CRP was above 45 milligrams per liter, then 85% came to that colectomy. And then what we do now in practice is simply to look at the patient on the 3rd day of intravenous steroids, and if they're in that cohort with a high CRP and high stool frequency, we go ahead and give them rescue therapy. But we do make contingency plans as well. We're trying to move decision-making to the left, because you remember that Canadian data I showed, which showed that the longer you were in hospital with physicians faffing around, then the higher the mortality. And we discuss with the patient what their views are. We talk through with them about the prospects for modifying the pattern of disease. And clearly we consider, is it their first presentation? Is it relapse of established disease, relapse in spite of immunomodulators? And we get the consultant surgeon coming around, not sharpening their knife and looking as though they're dying to operate, but simply so they can introduce themselves to the patient, talk through what surgery might mean, whilst there's still a chance that medical treatment will work. And yes, we also introduce the stoma therapist, because you can't have a surgical discussion leaving patients worrying what a stoma might mean if they aren't educated and advised about that. Doesn't frighten them. It's informing them. They're talking, and if you wait until it's inevitable, that's not a time to have a constructive discussion. But you've then got to decide. You've got to decide, are you going to use cyclosporin? Are you going to infliximab? Or sadly, some less experienced colleagues still opt for prevarication, and we know where that leads. And these are our own data, different to the Canadian data I showed, which illustrate the same point. John Randall showed that the longer you were in hospital, the higher the risk of major complications. The previous data was related to mortality. This is simply complication rate, and it's pretty frightening actually, because that goes up to 100% on the y-axis. So complications occur, but they're more common the longer patients stay in hospital. And look what surgeons can do. Professor Fernando, I hope you're impressed. This is total colectomy through a single port, stoma. No big laparotomy. I'm really, really impressed by Neil Mortensen showing me this. And this is the potential. Of course, you don't want surgeons practicing in an emergent case with acute severe colitis. But if they're a very experienced laparoscopic surgeon, you can do laparoscopic colectomy in an urgent setting safely, but safety matters most. And if the safest way is an open laparotomy and colectomy, then that's what should be done, depending on the experience of the surgeon, the facilities available in the hospital. So what toys do physicians have? Cyclosporin or infliximab? Well, there have been 2 randomized controlled trials. This is one, it's a French study and randomized 115 patients. And 10 years ago, it showed that cyclosporin was no more effective and infliximab no more effective than cyclosporin in steroid refractory UC. And they defined their endpoints as treatment failure, which are pretty robust. You need a colectomy, death, serious adverse event, or relapse within 3 months of having treatment. And you can see there really is no difference between cyclosporin and infliximab. And furthermore, when they followed up, and they published this 2 or 3 years ago, followed up the proportion of patients who had a colectomy who either received infliximab or cyclosporin, and you don't need to be a statistician to tell there's no difference between these 2 lines. And we in the UK did a study on called Construct, which was published 5 years ago. Again, a randomized controlled study. And what we were interested in there was quality of life. And so we examined that over an extended period. We had a larger sample size of 270 patients. And guess what? There was no difference between cyclosporin and infliximab. Doctors like giving infliximab, nurses like infliximab over cyclosporin because it's easier to use. Cyclosporin is a shed load cheaper, works just as well. And more importantly, to my mind, if you use cyclosporin, it gets out of the circulation within hours if a colectomy, emergency colectomy is needed, whereas infliximab hangs around for weeks, increasing the risk of infection. And of course, there are secondary outcomes and mortality. And in the Construct study, we found that in the Construct study, we found that 3 patients who were given infliximab died. Gosh, that one was at 20 days, another 64 days, another at 278 days. Was none in the cyclosporin arm died. What about the French study? Well, 3 patients died as well, but all were in the cyclosporin group. This is a serious disease. It has a mortality, and it behooves clinicians to be on the wall using indices to help their clinical judgment, supported and working with the surgeon in the interest of the patient. Some people say, well, we just need to give more infliximab. And there's been a study from 3 centers in the United States with over 200 patients, and some had 10 milligrams a kilogram or had infliximab given at just a week apart, and that's what is called accelerated infliximab. But the colectomy rate at 3, 6, 12, 24 difference was no different at any time point. And I think that people who advocate just give more and more infliximab are physicians who can't face the fact they've got to make a decision about calling in their surgical colleagues. And you do a disservice to patients if you don't face up to those decisions. And furthermore, if you swap from one to the other, as Narula now in Toronto in Canada did a systematic review, showed that yes, you can reduce the risk of colectomy. You get a short-term response almost in 2/3 and remission perhaps in 39%, but you still got adverse events. And in this French study, the JETAID study, it showed that people who had cyclosporin after infliximab or infliximab after cyclosporin, so they're both circulating together, 1 patient died at the age of 45 from pulmonary embolus, and there were 16 serious infections with liver abscesses and pneumonia. And it depends on the price that you want to pay. What then happens if people do respond to prednisolone? Well, what we do in Oxford is to convert them onto oral prednisolone after 5 days of intravenous treatment. We monitor them for another day or two in hospital, continuing to monitor their stool frequency and CRP. And if their stool frequency on the 7th day is 3 or less with no bleeding, we call that a complete response, and we just give them 5-ASA and usually start azathioprine when they're reviewed in clinic. Increasingly, though, we're using vedolizumab rather than azathioprine, and that's been driven by the pandemic. But if they have an incomplete response, so that's anybody who on the 7th or subsequent days have bleeding or a stool frequency of more than 3 times daily, then they have a high risk of colectomy. Over half come to colectomy within the following 12 months. And so we electively start those on advanced therapies. For cyclosporin, then when patients respond to intravenous cyclosporin 2 milligrams a kilogram, we monitor the levels, so it's between 100 and 200 nanograms per ml, and then convert them to oral therapy, and we give 2.5 milligrams per kilogram twice daily, a total of 5 milligrams a kilogram each day. And then increasingly, we're switching straight on to vedolizumab, which is gut-specific immunosuppression of an anti-integrin, but simply because of its safety. And but if in the conventional approach is to discharge them on decreasing prednisolone, continue the cyclosporin for 3 months, and then to start another immunomodulator as they're about to stop the steroids. And what we're trying to do there is increase safety by reducing the heavy immunosuppression risk of infection. The further data from JetAid so that you can do the cyclosporin to vedolizumab switch. I'm embarrassed to say that I didn't check whether vedolizumab was yet available in Sri Lanka, although I know that it is being launched in India. And it is a very useful drug. Patients love it, doesn't need azathioprine, and they hate azathioprine, and they because of the side effects and the systemic immunosuppression, and it's the safety of vedolizumab which is so appealing. And finally, coming down to the future, because when patients leave hospital, then they want to know, am I going to get readmitted with another episode, or what does the future hold? And I've highlighted the difference between how we define complete and incomplete response based on the stool frequency and bleeding on the 7th day. And Daniela Bojic did some work when she was over from Belgrade as a fellow following up the original 1996 cohort. And those patients who, small numbers, yes, who'd had a complete response, then over a 15-year period, a third still came to colectomy. Remember at the very start, I said that if you had a single admission with acute severe colitis, you still had a 40% chance of colectomy over the time, over a lifetime. Whereas those patients who had an incomplete response, this is only a week after they were first admitted, remember, then 3/4 came to colectomy. And I think that helps manage expectations. And it's not surprising that within those groups, the duration of remission varied substantially. So what I've tried to take you through in the current management of a patient hospitalized with ulcerative colitis is the different stages when you can predict what's going on. On admission, then you count the number of true love and witch criteria, and think about using the admit ASC criteria that Vipin Gupta developed based on CRP, albumin, and endoscopic severity, because that predicts steroid failure. At the very least, monitor their stool frequency, CRP, and albumin during their stay. And our Oxford Index that published in 1996 just takes the stool frequency and CRP, because if their CRP remains over 45 milligrams per liter on the 3rd day, then the large majority come to colectomy, that's when you need to make a decision about using rescue therapy. And the PUCI I haven't mentioned, although it has been validated in adults, but primarily for children. Then the pediatricians use this simple index for predicting steroid failure in children. But after patients have come into hospital, when they avoid colectomy and they're discharged, then about a third will be readmitted. But the patients who have a complete response with no bleeding and the normal stool frequency have a particularly good outcome, 5% colectomy at 1 year, 32% at 10 years. Whereas incomplete responders have a much, much higher risk of colectomy, over half within a year and 3/4 within a decade. So I would conclude that prevention is best. Use the criteria I mentioned for predicting the risk of hospitalization and identifying those patients at risk at diagnosis, because those are the ones you want to monitor most closely and get onto the front foot with using the advanced therapies, or at least the immunomodulators such as azathioprine. Use the clinical, the laboratory and endoscopic criterion on admission, because that predicts the risk of surgery, the number of true love and wits criteria, the admit ASE score, which I remind you has been validated in Delhi, and using the UCIS as your way of describing the severity of the colitis. And then on the third day, stool frequency CRP is a useful backup to help determine the course and help manage the patient's outcomes, get the surgeon involved and get the therapist. But you've got to act on those criteria. Contingency planning. And we use cyclosporin in Oxford, if they're not already on azathioprine, but if they're already on azathioprine, then we go for infliximab. Don't use one and then the other, but go for colectomy. And if in doubt, call a friend. Don't duck those difficult decisions. And please, if you are coming to the UK, come and visit us in Oxford, because you would be most welcome, and I look forward to continuing the enjoyable interaction between Oxford and Sri Lanka. And thank you to all my friends and fellows there who've been in Oxford and helping with this work. Thank you very much indeed.
Thank you very much, sir, for that insightful oration. With that, we have reached the conclusions of today's proceedings. I would like to invite the Secretary of the Sri Lanka Society of Gastroenterology, Dr. Hasitha Wijewantha, to propose the vote of thanks.
Good evening. Our chief guest, Dr. Sanjeev Munasinghe. Dr. Sanjeev Aryasinghe, President, Sri Lanka Society of Gastroenterology, past presidents of the society, distinguished invitees, colleagues, friends, and ladies and gentlemen. We have come to the end of ceremonial inauguration of the annual academic session of Sri Lanka Society of Gastroenterology 2021. It has been a difficult but successful journey amidst the challenging circumstances faced due to COVID-19 pandemic. At the outset, I would like to thank our chief guest, Dr. Sanjeev Munasinghe, Secretary, Ministry of Health, and the guest of honor, Dr. Asela Gunawardena, Director General of Health Services, for gracing this occasion. Sirs, your presence today in our inauguration is a great encouragement to all gastroenterologists and GI surgeons in Sri Lanka. Thank you for taking time out of your very busy schedules to be with us tonight. The main highlight of today's inauguration ceremony was the Nihal Marcus oration. Today, the orator was one of the world's leading experts in inflammatory bowel disease, Professor Simon Travis, Professor of Clinical Gastroenterology, Oxford University Hospitals NHS Foundation Trust, United Kingdom. It was a great honor and a privilege to have him as the orator this year. On behalf of the Sri Lanka Society of Gastroenterology, I extend my heartfelt gratitude to Prof. Travis for being the orator tonight despite his busy schedule. We are thankful to Dr. Nageshwar Reddy and his team from Asian Institute of Gastroenterology, Hyderabad, India, and Dr. Amit Maedeo and his team from Beldota Institute of Digestive Sciences, Mumbai, for conducting the live endoscopy workshop. We are grateful for the technical and IT staff of both institutes as well for the wonderful job in seamless live transmission of the workshop from India. I must thank Dr. Nilesh Fernandopulle for single-handedly carrying the burden of coordinating and organizing the live endoscopy workshop from the Sri Lankan end. Our heartfelt gratitude goes to the world-renowned experts who have agreed to share their knowledge with us during tomorrow's academic session as well. Dr. Mananjala Senanayaka and his team, who had worked hard to prepare the picture quiz for tomorrow's academic session, also need special appreciation. We are very grateful for the services of all the past presidents and past council members of the Sri Lanka Society of Gastroenterology in bringing the society to this level. Special note of appreciation goes to all the past presidents and the past council members who are here and not here with us tonight. There's a saying, alone we can do so little, together we can do so much. This year, we as a group, the Sri Lanka Society of Gastroenterology, achieved many things as our president already mentioned. An academic session of this caliber, which includes satellite centers in 33 peripheral hospitals in all parts of Sri Lanka, needs a lot of planning and hard work by many people. We are glad to say there have been more than 650 physical and virtual participants at today's endoscopy workshop. I thank all the consultants in the satellite centers who coordinated with us to conduct the virtual sessions and also the participants who made it a great success. I also thank all the sponsors who came forward to provide the financial and logistic support to conduct peripheral satellite sessions. I greatly appreciate the hard work and dedication of Dr. Nilesh Fernandopulle, who centrally coordinated the satellite sessions on behalf of the SLSG. I must thank all the gastroenterologists and GI surgeons all over Sri Lanka who personally supervised the virtual academic sessions in peripheral centers to make sure they function without an issue. Event of this caliber is never possible without good financial support. We are lucky to have a group of generous industry partners who always come forward with financial assistance for the activities of the SLSG. I take this opportunity to thank our diamond sponsors, Boston and Life Scientific, platinum sponsors, AJ Medicals and Abbott Sunshine, gold sponsors, George Stewart and Ferozans, silver sponsors, CIC, Seven Shine Pharmaceuticals, Zydus, Asiri Group of Hospitals, Kish International, Calbi Pharma, Cipla, and MediEquipment. We also had 10 bronze sponsors. I am not going to read out their names in the interest of time. Mr. Samira Pereira of Zydus Pharmaceuticals needs special appreciation for distributing the posters and flyers of this event all over Sri Lanka using his network of medical representatives. I must thank Mr. Sanath of Boston and Mr. Sahan of Kish International for helping us with registrations for the endoscopy workshop. I thank Ms. Janani Ilan Gamage, our secretary, who did a great job behind the scene in organizing this event. To organize and coordinate the many aspects of an academic session of this caliber needs an experienced and reliable event manager. We thank Ms. Dilisha Bulat Sinhala and her team at Asia Tours and Events for all their effort in making this event a success. We also acknowledge and thankful for the services of Mr. Clifford and his staff at the Hotel Cinnamon Grand to ensure smooth functioning of this event and accommodating all our requests without any hesitation. This evening's proceedings will be made more glamorous by the Channupuli dancing troupe, and we appreciate their colorful contribution as well. We thank Supun and Darshana, who will be providing music with the violin and saxophone tonight during the dinner for making our inauguration ceremony even more colorful. Two compeers tonight, Randunu and Kalani, need special praise and appreciation for their efforts. Under the leadership of Dr. Sanjeev Arya Singha, we as the SLSG were able to achieve several significant milestones this year. I thank all the council members for putting their full strength behind us under the leadership of our president. Dr. Dinamitra and his editorial team did a marvelous job to compile the first ever publication of the SLSG. Dr. Achini Vitanachi and her team prepared the much needed endoscopy curriculum for endoscopy trainees. Dr. Mananjala Senanayaka and Dr. Jayani Manchanayaka and their team prepared an evidence-based guideline, evidence-based comprehensive clinical guideline on management of acute variceal hemorrhage in cirrhotic patients to uplift the patient care. Dr. Kulisha Kodisinghe and his team made sure our academic activities did not limit to a single annual academic session by organizing a series of monthly webinars and monthly journal clubs which covered all the important aspects of gastroenterology, hepatology, endoscopy and nutrition. Last but not least, to all of you ladies and gentlemen who graced this occasion tonight. This event would not have been this beautiful without you all, the audience. I thank you all for coming here despite your busy schedules and other commitments. Now I invite you to enjoy rest of the night with dining and wining and music while adhering to social distancing rules and taking care of yourselves. Thank you very much.
Thank you very much, sir. At the end, we would like to leave you with a mesmerizing dancing performances, a lineup of mesmerizing dancing performances. Before that, I would like to request the dignitaries of the head table to be seated in the audience.
Check. Ladies and gentlemen, tonight's dance performances are brought to you by the Channa Uppuli Performing Arts Foundation, and they are all choreographed by the two of the most veteran dancers in Sri Lanka, Channa and Uppuli Vijayawardena. To give a little introduction, these dancers have traveled across the globe, taking Sri Lankan dance out into the world, and are known for their unique ability to incorporate traditional Sri Lankan dance and to mold it together with contemporary dance moves and to bring it to a modern audience. And they have in fact captivated many an audience over time across the globe. The first dance act is a fusion of traditional Sri Lankan dances with a modern twist. Enjoy. that was nothing short of mesmerizing. Ladies and gentlemen, the second performance is a performance including a traditional fusion of Sri Lankan drums. This will be performed to you by a team of percussionists led by Mr. Jananath Varakagoda, who is a renowned percussionist himself in Sri Lanka. I'm sure these rhythmic beats of traditional Sri Lankan drums will keep your feet tapping all along. Let's welcome them with a big hand. What a truly magnificent battle of the drums. I think the captivated faces of the audience speak volumes. Let's give a big hand one more time. Ladies and gentlemen, the last dance performance for the night, again performed to you by the Channupali Dance Troupe, is an interpretative dance to a popular Sinhalese love song. The song itself speaks of the longing for love. I bet most of you can relate to that experience. These graceful ladies will take the stage one last time to entertain you and to enthrall you with an expressive dance act. So let's see what they have to offer. Let's give a big hand and welcome them one last time on stage.
මසානයට අතවනලායිමු මග බලන් උද්‍යානයක කෙළවරට වී ඔබ ඇතින් නින්දන් ඉන්නවද රත්තරන් මංගාවින්ම උනොහොම නොදී මසානයට අතවනලායිමු මග බලන් උද්‍යානයක කෙළවරට වී ඔබ ඇතින් නිදන් ඉන්නවද රත්තරන් මංගාවින්ම උනොහොම නොදී හාදු දෙන වැස්සේ තේදුන්න අස්සේ අපි පාවෙමුද තුරුලටම වී ඔබේ ඇස් නස්සේ මං මාව දැක්කේ සංසාරයම මම නුඹ කිවී තව ඇතින් නිදන් ඉන්නවද රත්තරන් සංසාරයම මෙය මට නොදී වසානයට අතවනලායිමු මග බලන් උද්‍යානයක කෙළවරට වී ඔබ ඇතින් නිදන් ඉන්නවද රත්තරන් මංගාවින්ම උනොහොම නොදී වැටකඩුළු අස්සේ මල් පිපුණු බිස්සේ අපි හැංගෙමුද උණුහුමට වී සමනල පස්සේ දුව පැනපු කාලේ දැන් මට දෙන්න නුඹ මගේම දී ඇයි ඇතින් නිදන් ඔය තරම් රත්තරන් මං ආවොත්ද නුඹ මට හිමි පසානයට අතවනලායිමු මග බලන් උද්‍යානයක කෙළවරට වී
Thank you very much for that glamorous performance. Let's give another round of applause to Channa and Nupuli Dance Group. Ladies and gentlemen, with that, we mark the end of the inauguration ceremony of annual academic session Sri Lanka Society of Gastroenterology. I would like to ask the audience to rise for the ceremonial procession to leave the hall, and after that, to join for cocktails and fellowship.